The American healthcare system has been called a lot of things. The most advanced in the world, the most expensive in the world, easily the messiest in the world. For people trying to fix it, though, there's another way to look at it, as the most complicated sailor's knot ever tied. Like any good knot, it looks easy to undo. But like any good knot, it's not. Pull on a loose strand and the entire thing just tangles up further. Try to simply cut through it and everything it's supporting collapses completely. And when it comes to healthcare, those things that collapse can be the health and welfare of entire families, not to mention our national economy. With us today are three of the best experts on knots the country has. The Honorable Tom Daschle is Special Policy Advisor at Alston & Bird and a Distinguished Fellow at the Center for American Progress. A United States Senator from 1987 to 2005, he is also the only senator in American history ever to have served as both minority and majority leader of the chamber. He was a national co-chair of President Obama's presidential campaign and remains one of America's leading voices on health care reform. The Honorable John Porter is Chairman of Research America and Vice President of the Foundation for the NIH, Chairman of PBS, and a member of the Institute of Medicine and the Council on Foreign Relations. He served for 21 years in the U.S. House of Representatives and chaired the Appropriations Subcommittee that funded domestic health programs, including NIH and the CDC. He's currently a partner in the Washington law firm Hogan & Hartson. The Honorable Billy Tauzin is President and CEO of the Pharmaceutical Research and Manufacturers of America. Prior to coming to PhRMA, he served 26 years in the U.S. House of Representatives, where he was chairman of the Committee on Energy and Commerce. He began his career in public service as a member of the Louisiana State Legislature, and as I've discovered in the past day, he's also one of the best storytellers I've ever met. Now, I think the best way to begin the conversation, and Senator Daschle and Congressman Tauzin will address this first. Congressman Porter has a few different kinds of remarks he wants to make. I think the best way to begin this, though, is to frame the session with the question that's the title of the session. Is 2009 1993? And if it is, or if that's the way it's turning out, how can we fix it before we have another failure to enact reform? Senator Daschle, would you like to begin?
Well, Jeff, I think the circumstances today are so different, and that's partially what gives me the optimism that I have with regard to our ability to address the issue. I wish we were farther ahead in the legislative process than we are, but nonetheless. First of all, the circumstances with cost, access, and quality have all gotten dramatically worse, and we've talked about that, so I won't elaborate. But even with regard to the legislative environment that we're facing, you've got a president who has made this the number one issue. That's never happened before. You have stakeholders like Billy who are at the table, continuing to participate and be engaged, and that's not happened before. The doctors actually endorsed health reform. I should say the AMA endorsed health reform, and that is a positive development. In 1993-94, you had real friction between some of the committees and the Clinton administration. Today, there is no friction. That's probably an exaggeration. Yes. There's less friction. There is a certain degree of comity and of partnership between the five committees, or among the five committees, and the president, and that's a plus. And then finally, the strategy itself has changed. Rather than the president lay down a 1,300-page bill, as everyone knows, this president has chosen not to do that. To say, look, here are my principles. Let's see if we can achieve this, and go at it, and we'll guide you and work with you, and see if we can reach consensus along the way. So all of those circumstances are significantly different, which would lend itself, I think, to some expectation that we've learned the lessons of the past, and because the situation is as different as it is from what it was 15 years ago, and the other factors I mentioned, you have a reason to be more optimistic.
Great. Congressman Tauzin, some of our conversations yesterday gave me the sense that you feel while the president hasn't, as Senator Daschle says, laid down a 1,400-page bill and said, enact this, I'll wait for it on my desk tomorrow, that may not necessarily have been, he may have gone a little too far in the other direction. Is that the sense you have?
Well, let's look back at the 1990s. I was there. I was a blue dog Democrat on the Energy and Commerce Committee. What happened in 1993 was that Hillary Clinton brought a plan to us, all already baked, and there wasn't any other plans. There were no other options, take it or leave it. I remember she brought it to Mr. Gingrich and said, I've got a plan. Do you have a plan? He said, yes. My plan is to beat your plan and then take over the House. And that's precisely what happened. It was a contest over a single-payer system, a single plan, and you saw what happened. There was no democracy involved in it. It's take or leave it. The president decided to do it very differently. He decided to allow democracy. And somebody said democracy is the worst system of government on earth, except for all the rest. And I think that's what's going on right now. There's a lot of democracy is going on. And while there's a lot of alliance among the committee chairs on getting something done, there are a lot of plans out there. A lot of different contesting ideas. In addition, because it's not a single-payer plan, there are a lot of things that now become controversial. It's not a take it or leave it. Do you want a public plan? Do you want a co-op? Do you want a backup plan? Do you want to settle issues like CER? Do you want to fight over follow-on biologics? Do you want to, literally, how do you fund it? Who's going to come in and pay what? And who's going to be charged for what? There are lots of controversial issues all of a sudden that are being debated in a much more democratic forum. He decided on that course. We complimented him. But the fact is it's a messy course. And it's gotten to the point now where there is a lot of friction, not among the committees, but inside the committees. I think in the Senate, Tom, you'll probably agree with me, that there's a better chance that the two committees will be able to work out their differences eventually and produce a common product. While the committees in the House have a common product, there's a lot of fighting going on among the members who are going to make up or not make up a majority. You've got the progressives on the one hand saying, if you don't have a full-blown public plan, we're not voting for it. You've got the Blue Dogs and some new Democrats, some freshman Democrats who were elected in very moderate conservative districts that used to belong to Republicans, who's saying, if you put a public plan in there, I can't go home and win an election. And I can't vote for that. So you're beginning to see a hardening of positions in the House that has really slowed the process down. Did the president engage earlier enough or not? That's debatable. I mean, he made a judgment call that he wanted a democratic process because he felt 1993 was a mistake. I tend to agree with him. Did he engage early enough? Did he engage too hard? That's a good debate.
Has he lost his chance, do you think, to hit harder now and say, all right, I'm going to guide this process more aggressively?
Well, let's go back to the town hall meeting quickly. We had this big town hall meeting in the White House. I was there. And I was part of the discussion with Nancy Ann. It was, I thought, very productive, very good. Then we had a big show gathering with the president. And the president was asked a question by Senator Grassley. I don't know if you remember it. Senator Grassley said, are you going to include a robust public plan? And the president didn't say yes. What he said was that there are two arguments there. On the one hand, a public plan would create competition for the private plans. That would be good. On the other hand, a public plan done incorrectly might drive out private insurance. Employers might dump their workers into the public plan, and we'd lose employer-sponsored insurance for America. And so here's what I'm going to do. He said, I'm going to let you try to work it out in the private sector if you can. But if you don't come up with a good private sector solution, then I'm going to offer a public plan. So the question is, did he move too early in insisting on a public plan? Or did he let democracy go too long before he did? I don't know, Tom. What do you think?
To answer your question, Jeff, I don't think that it's too late at all. In fact, you've seen a ramp up in the last week where he has become much more engaged. He had Harry Reid and Max Baucus in his office on Friday. It lasted over 2 hours. It was a very good meeting. And over the weekend, as I understand it, he's made a number of calls to senators and members of the House, and especially to Henry Waxman to see what, if anything, they can do to resolve the impasse they have in the Energy and Commerce Committee, Billy's old stomping grounds. So he's as engaged as a president has ever been on health care right now, and I think it's only going to continue to go up.
I tend to agree with that. I think he's going to become more and more engaged, and I think while the chances of getting a bill out have dropped a little bit, I think Tom and I agree upon that. I think the more he engages on a personal level, the better chance he has to get that, particularly in the House, to get a bill through that very small eye in the needle between the blue dogs and others who have problems with it, and the progressives who insist on their way of the highway. And it's a very, very narrow needle. If the president doesn't engage, my prediction would be that it's not going to happen. He's got to now.
Congressman Porter, I know you have some more general thoughts.
Jeff, I just wanted to begin because I knew Tom and Billy would get into the details of this. I just want to say a few things. I want to thank the Aspen Institute and its wonderful staff for bringing us all together. This is a wonderful, wonderful conference that really, I know when I come here, I realize how little I know and how much I get educated by the people I'm privileged to hear and work with. And I also realize what a privilege it is for myself and Amy, my wife, who's the head of the Foundation for NIH, to work with people of science. It is truly wonderful for us to be able to be engaged and not be scientists. I think that we are doing things smarter in this country. And as I'm the old guy here. I really think that you can sense the advance of civilization. And I don't know how many of you were privileged to sit in with Dr. Oz the other night. There's a young leader who is really talking sense. And I sat there saying to myself, I agree with most everything this dynamic young surgeon is saying. Now we have a dynamic young president who is, and by the way, Billy's from Chicago, and Chicago's not nearly as bad as Louisiana. I want you to know that.
You don't know Chicago.
Yeah, I do. I came to Washington and went to candidate school in 1979, and there was a guy running for Congress, a Republican running for Congress, who was in that group, and he said he just came from Louisiana, and the night before his opponent shot at him with a revolver. So we aren't quite that bad. But we have this
Al
one...
Capone?
years ago. But I came to D.C. first, right out of law school, and I was appointed by the Eisenhower administration. And by the time I got to Washington, I was working for Robert Kennedy. And John Kennedy was our president. And I can tell you, I was never more excited and inspired by the possibilities of what government can do. And I feel exactly the same way again with this president right now. I think that we have to tackle these big changes and make them happen. This is our window of opportunity. And if we don't take advantage of it, I see it as kind of idealism versus cynicism and special interest versus national interest. And it's time for us all to step up and make this happen. And we can do this if we set our minds to it. It can be accomplished. Now, I have to tell you, unlike my friends, well, Billy has Republican and Democrat. Tom's always been a Democrat.
John Breaux called me a transvestocrat.
Transvestocrat. I'm a moderate Republican. People like me are in a museum now. And I was in the minority when they were in the majority. And I was also not an authorizer, I was an appropriator. And what appropriators do, first of all, we pay no attention to authorizers.
That's right.
Nothing. We just go about our work. But we also never engage with the media and always keep our heads down. So I wasn't involved in this like they were. One other thing that I would add in comparison, right at that time, the House bank scandal had hit. Do you all remember that? And a lot of members were really worried about their future. And I think that played on what they ought to do about health care reform. Let me bottom line my opinion on this. Something called health care reform will be passed and signed into law. This president has staked his entire presidency on it. Democrats, if they think they can vote, the conservative ones, can vote no and survive in those districts, they might be having to think that they're going to have no support from the White House and nothing to ride on like they rode into office on in 2008. So I think something is going to pass. The question is not whether something's going to pass. The question to me is what's going to be in it. And I think that the real issue probably we can solve the other ones. The real issue is the fiscal issue. Can we pay for it or can we not? And we're going to have to be very creative. They are going to have to be very creative in figuring out how to pay for it. I think they can get the rest of it. The public plan, for example, I think they're probably not going to have a full-fledged public plan. They might have it by regions or states. They might have cooperative. But if they put the public plan in, I think they'll lose the moderate Republicans and the moderate Democrats as well. So the moderates are key here. Fiscal conservatism is very important to getting this done, but I think we can get it done.
Jeff, can I add something in defense of those poor old blue dogs who are sweating it out right now? What they're deeply afraid of is getting BTU'd. Anybody remember that? I got BTU'd. I know about it. BTU'd is a symbol now in Washington for having to vote for something in the House that's hard for you to defend at home, and it gets fixed in the Senate. But you've already cast a vote. It's hard to defend back in your home district. And they have the notion that the Baucus committee is probably going to come up with a compromise on some of the elements they're concerned about, pay-fors and size of the bill and public plan, a number of issues. And they will have already voted for the Waxman bill that's harder for them to defend at home in their districts. So they legitimately are saying, if you're going to make those changes in the Senate, why don't you make them in the House so we can vote for them now rather than having a bad vote on our resume when we go back home. That's a legitimate concern, and that's one I think that the leadership in the House and the President are wrestling with.
Well, I think there's a second.
Go ahead, Tom.
I was just going to say there's a second concern that I'm fully supportive of as well, that the Blue Dogs, to their credit, have put their focus on, and that's cost containment.
That's right.
You know, Elmendorf and the CBO has made it quite clear that we're not succeeding in our effort to substantially bend that curve that everybody proclaims an interest in doing. And, you know, and I think we can do a better job, and I think it's going to take more meaningful public policy approaches to do that, and we can get into that discussion if anybody wants. But the Blue Dogs, as I say to their credit, have put a real focus on that as well. We've got to do that. We will not have succeeded if we haven't bent the cost curve effectively. And the jury's still out on whether we're going to get that done or not.
If the cost curve can be bent, how much does that mitigate against and you're talking about the cost of health care, not the cost of the plan, correct? How much does that mitigate against the fears of an explosion of the deficit in paying for the plan? Do you then offset that expense?
Well, to a certain extent, but keep in mind, you know, the next 10 years, the United States is going to spend approximately $35 trillion on health care. $35 trillion in the next 10 years. And just to keep that in perspective, as you look at what the government, what the House and Senate are trying to do to pay for the initial 10 years of new infrastructure so that we can bend the cost curve in the out years. And they're looking at $1 trillion to maybe $1.2 trillion. So when you look at the fact that it's 1/35 of the overall amount, and keep in mind that, you know, there are only three ways to pay for all of health care. There's the government through taxes. There is all of what happens in the private sector through insurance and everything else, and then there's out-of-pocket expense. But when we look at the global cost, whether it's a little bit more government or a little bit more out-of-pocket or a little bit more insurance-driven, that isn't as relevant as what we do to that overall global amount that we're committing to in the next 10 years. So I think we have to keep that in perspective. But there's no reason why we can't come up with a $1.2 trillion offset for what we have to do to put that infrastructure in place. Is it painful? Of course. But there's revenue, there are cuts, and there are certain modernization approaches that can bring down costs. But those are the only three buckets to come up with that $1.2 trillion. How much in revenue, how much in cuts, and how much can we squeeze out in modernization? And that's really what they're trying to do right now. None of them are easy.
Let me get granular with you. The granular answer is that the real bending of the curve occurs when you take a sick care system and bend it into a healthcare system.
That's right.
And that bending of the curve is a long curve. And it's also not scorable. So when Elmendorf tells you that you're going to build a big deficit, he's basing it upon scorable numbers. Now, many of you may not understand that.
In 10 years.
In 10 years. That's an important number. There was a lady around Washington that we killed at one point. Her name was Rosie Scenario. Rosie Scenario was a symbol of what's called dynamic scoring. I haven't had a single person who ever come see me in Washington, you guys probably will know what I'm talking about, who didn't come and tell me, Billy, if you spent some more money on what I want you to spend it on, you'd really save money. Everybody had that argument. And sometimes it's valid and sometimes it's not. At some point in our history, we accepted everybody's argument. And she became Rosie Scenario. You know, we just spend some more, we'll save it over here. And the result was we got deeper and deeper in debt. And so you remember when Mr. Reagan came to town, we shot her. And we went to something called static budgeting, which means that you have to actually find a pay-for, which is what Tom was talking about the Blue Dogs are insisting upon.
In 10 years.
But the problem is you got to do it in 10 years. And you got to really account for it. If you look at the bill in the House and in the Health Committee, you see that most of the healthy living provisions, the prevention provisions, the provisions that would encourage all sorts of diet, exercise, disease awareness, early detection, early disease maintenance, those are all pilot programs for the most part. And they don't score very well, certainly not in 10 years. So take that to heart when you think about this. I don't think you can possibly turn this healthcare system around into a real healthcare system without some more cost. And you still got to take care of all the sick people like me who didn't take good care of themselves. So you got to do both for a while before you bend the curve. And that may take 20 years, and it doesn't score. So Elmendorf may be technically right, but maybe we ought to resurrect Rosie for a little while and give her a chance to breathe and give her a chance to turn this system around so we really take into account what we can do in prevention and healthy living. I saw some numbers today. You know, our health care results would be equivalent in a nanosecond to Europe and Japan if we didn't live so unhealthy. And that's our biggest problem. If we could get a system that encouraged us, incentivized us to live healthy, we'd be in the ballpark immediately. But that's going to take more than 10 years.
And one of the great difficulties is that the prevention and wellness piece of this is not scored. So you don't get any advantage from saying we're going to do these things because Elmendorf says I'm following the rules of scoring and it doesn't score. I agree with something that Billy said earlier.
Just one thing?
No, two, actually. He said it wouldn't be smart for the House to go ahead of the Senate on this because the Senate is going to come up with something more conservative, something more bipartisan. And I think the leadership in the House has to realize that, and the action should occur first in the Senate. If they try to do it in the House, it's crazy. It's just dumb politics. Let me add something that doesn't apply to this, but I think it's got to be something that people ought to begin thinking about because it relates to the prevention piece, and that is, isn't it time that the United States went to capital budgeting, where we look at things that are long-term investments in our society, and they are taken away from the day-to-day, year-to-year costs of doing things. We improve our highways, and we make the investment to do so, but it isn't. It's part of the annual budgeting process. it seems to me that the way we get through this next period where we have very large deficits is to look at our whole budgeting system and decide what's long-term and what's day-to-day or year-to-year and divide them into two.
Can I react to that? That's a good idea if you do it. You know, people say we ought to run government like business. Business does that.
Sure.
We have capital accounts, we have mortgages on our home, and we have operating accounts to run our businesses and to run our homes. But the difference is we pay down our mortgages and businesses pay down their debt. Now, if you combine that kind of capital budgeting with a plan to constantly pay down the mortgage, you got a good deal there. I think we ought to look at it.
I would just say we have to be a little. I agree with that in concept, and I completely agree that we ought to relook at the way we do this. But General Motors and Lehman did that too, and we're not, so it isn't just that. But I think
follow that.
Yeah. There are models we don't want to follow, and it's agreeing on what is a capital investment. That's big.
Yeah.
I've been in many rooms where we've had that discussion, and nobody can quite agree on what a capital budget really looks like. But in concept, that's exactly right.
Given all the combat over the details in the bill, is it possible this year, do you think, or advisable, to pass a stripped-down, even mediocre bill, and in later years sort of implement it or amend it into excellence or something closer to excellence? And if so, I'm interested in what is the minimum each of you would need to see in a bill that went through this year or early next year to make it more than just an empty legislative.
Well, I would start by just saying, look, if we can agree that there are three components to the problem: cost, access, and quality. You know, how do you address cost? Well, let's start with the easiest one. You address access, and that's by far the easiest to solve. You have to have a mandate, and you have to have a subsidy. And with a mandate and a subsidy, you can get to about 97, 98% of everybody in the country. And so that one isn't that difficult. There are a lot of different paths to get there. Quality, I think, is a lot harder. Comparative effectiveness research, I think the use of evidence-based medicine is essential. More transparency, a lot more IT. Payment reform is critical. I mean, all of those components have to be part of quality. And then cost containment also is part of that. But part of cost containment has to be coming back down to the base of the pyramid and starting with prevention and wellness, and then addressing payment reform as not only a quality item but a cost item as well. But clearly, those components are all necessary if you're going to do anything to really make the system what it needs to be. You will, even if we pass a moderately good health reform package, you're going to have to continue to build and refine and grow. I mean, that's going to happen. But you have to have that framework in place, and it seems to me at least those are the components of the framework you need.
Congressman Tauzin?
Well, let's start with the fact that I don't think a mediocre bill is in the winds. I mean, you don't have to sacrifice a real solid approach on all those elements and still get a bill passed the president can sign. There are a few tricky things. The size, how you pay for it. Congress has done that. Good, bad, and kind of well from time to time. They can work that out. The public plan, you know, that's going to have to be a compromise. I was at a dinner the other night in Washington with a lot of thought leaders, and they included a number of liberal members of the House, and they were asked whether or not the final package would include a full, robust public plan. Not a hand went up. I mean, there's a common belief there's going to be a compromise, and it's probably going to come out of Senator Baucus's committee, and it's probably where you can pass a bill. So you might have to compromise on one or two features like that. But the great effort to ensure as many Americans as we can so they can get the benefits of preventative care and early detection and disease management, all the healthy living aspects. If you want to pass that, common ground. If you want to pass elements that focus on outcome and payments based upon good results instead of just shooting in the dark, as we were talking about yesterday, common ground among all the players. If you want to pass bills dealing with bending that curve and finding ways in which we can control efficiencies and if you will, mistakes in our system, there's so much spending by mistake. the common ground on those kind of things. The elements of how you implement it will be difficult. But you don't necessarily have to sacrifice the big components of that to get a bill passed. You just have to recognize you can't have it all your way, as they did in 1993. And so I don't think that's the choice. And I'll tell you something else. I don't think the president has a choice but to pass a bill. This is critical to him. It's critical to him, his party, and his success, not only in his early years, but his chances of a second term. This is critical stuff for him. I think Rahm Emanuel is going to do his best to make sure that not just a mediocre, but a substantial bill is passed that moves us along all three of those paths.
The only part that I might I'll let John.
Well, I was just going to say, there's a saying about making law is like watching sausage being made, and that is so true here. We're seeing all the elements come in, and the media is so good at reporting it all. But we have a difference that Tom alluded to in the beginning, and that is that the president has taken all the groups that have an interest in this, he's brought them to the table, and they are engaged. And many of the biggest really want to get this done. And I think that if we can keep our heads above the small details and work out the big picture proposals, that we will have a bill like Billy says. It won't be a minimum bill. It'll be a good bill. It won't be everything everybody would want to see in it, but it'll be a good start on that. And we will then in future years, Jeff, fix the pieces that aren't all the way we would want them.
Jeff, could I just comment? That John's comment is a good segue into. If I had to say where I think one of the toughest things is where we're really going to find some difficulty, it's cost control. We're talking $2.5 trillion, and so the stakes economically and financially for everybody are very, very high. And John's point about staying out of the weeds is such an important one. I worry the more we delineate the weeds, and the more clearly it's understood how much effective cost containment there is, the more understandably every stakeholder is going to be forced really to oppose those efforts. And it's why in this very room yesterday we talked about this idea of a health board, because I think if you could delegate the responsibility, stay out of the weeds, and just say, look, we're going to figure out a way to address cost containment without getting too specific, especially in the short term, I think we can avoid some of that. But the more specific we are, the more detailed we are, and the more we are successful at delineating how we're going to contain costs, the more we're going to have to figure out how we keep the stakeholders at the table.
Let me give you the big picture, though, because, we talk in politics. Let's talk country. Let's talk America for a second. We asked, on behalf of the Partnership to Fight Chronic Disease, which, as you know, eats up 75 cents out of every dollar we spend, mostly to repair damage done because we didn't take care of ourselves. We asked the Milken Institute to quantify it for us. And they came back with their study. You ought to look at it. It basically said that today, chronic disease, just those 5 big categories of chronic diseases, costs this country $1.3 trillion, most of it in lost productivity. That if we don't do anything about it today, within 20 years, it will be $6.7 trillion per year. What he also said was that if we do something about it today, if we put some of this stuff aside and compromise where we have to compromise, get this done and going, that we can save 1.1 of that 1.3 trillion per year. That's enormous. So I'm going to put it in simple Cajun terminology, the same way the doctor put it to me when he said, I got a medicine that might kill you. On the other hand, you're going to die. I said, bring it on. Okay, here's the choice. We can be a sicker, poorer, less competitive country, or we can be a richer, wealthier, more competitive country. That's simple. Where do you go? Where should the Congress go? You put it in those terms, when you look at those numbers, you look at the numbers Tom gave you, you work through those things. You work through those things because we're all in this together. We're not Democrats or Republicans, we're Americans. I want to tell you something I keep telling everybody at PhRMA. I've never seen a single patient come in the hospital and sign in as a Democrat or a Republican or conservative. We sign in as sick people, and we're looking for help, and we're looking for good results. And now our country is sick. It's on the table. It's not Democrat, it's not American, it's not libertarian, conservative, liberal. It's a sick country getting sicker. And when you got a sick patient getting sicker, you don't sit around and talking about the edges. You talk about how you can move him into good care and save his life. And that's what they're about in Congress. And all of you, all of us, have to make them see it that way and work through their, sometimes, can I say it? Sometimes they're petty differences, because sometimes they are.
This is the head of our pharmaceutical industry. This is not 1993. He's telling you that we got to get this thing done. The insurers...
Not only me, Harry and Louise.
Harry and Louise, the insurers. Yeah, they're on our. The insurers see 47 million new customers. I mean, it's entirely different. We have a good shot at getting this done. It's just a matter of getting through it and not getting, as Tom says, into the weeds. We just have to keep our heads above it.
You actually anticipated my next question. We hear a lot of questioning now about the reliability of that 47 million figure, number one, whether it's somewhat exaggerated, and number two, whatever the figure is, the percentage of that we're going to cover this year, next year, the year after, over time, is a consistently moving target. Is that 47 million a reliable figure of the number of Americans who are uninsured, and how many of them can we get covered in the near-term future?
I think it's important to understand when you say 47 million, you're talking about who during the course of a year at some point is uninsured. I mean, obviously some people are uninsured only part of that time. But there are two other statistics that I think are very important here. One is that with every 1% of additional unemployment, an additional 1 million people are added to those rolls. Now, they may be only uninsured or unemployed for a period of time, but they're added. 1% equals 1 million. The other one that I think is really important is to understand what several studies have now said with great clarity. Just because you have insurance doesn't mean you're out of the woods. 48% of the people who have insurance don't get the care that they need because they're so underinsured today. So we shouldn't get hung up on these numbers. We just know we have a huge access problem. You may be insured, but you still don't have the access you need to get the care you have to have. And even if you are one of those 47 million, your numbers are going to go up just because we have such an economic problem in our country today.
Let me tackle the numbers. You got 9 million in that group that are eligible for Medicaid, Medicare, at least. The Census Bureau admits it made errors in there. Some of them are in Medicaid, Medicare weren't counted. You got at least 9 million who could sign up and don't sign up for some reason or another. You got maybe 5 million kids eligible for S-chip who have signed up. You got 2.5 million seniors who are eligible for free, totally paid for health care under Part D pharmaceutical benefit who haven't signed up. No hole in the donut, no premiums, free. Haven't signed up. I was at a meeting in South Carolina with a lot of ministers talking about what's wrong with that. Where are those folks? Why don't they sign up? And the answer I got was a very, very complex answer about people not wanting to be seen, not wanting to be known, scared of signing up for one thing because they might lose another benefit, all sorts of reasons. But here's a solution. I mean, why not auto-enroll the 5 million children under S-chip? Why do we have to wait for somebody to be good enough for their kids to sign them up for something they deserve?
Absolutely.
Why don't we do a little auto-enrolling in the Medicaid and the Medicare programs? Why not auto-enroll those 2.5 million seniors into coverage for the medicines they need? It's crazy not to do that, I think. Our first problem ought to be to get people who are eligible for current programs enrolled in them. And then you got a smaller target in your final package. We know that a lot of these folks are here without American citizenship in that group. We don't know how many of those are working or buying. We get some crazy numbers on that, but because they're hidden in many respects, you don't know. That's a difficult issue. How do you tackle that? And that's one we haven't really debated a whole lot, but it's a huge problem. You can't have folks living in your society, whether you wanted them here or not, who don't have health care. You've got to figure out a way to make sure they get it, and they're getting it in many cases the worst way. You look at the numbers after that. You've heard this before in some other discussions. You got my kid living in Los Angeles, who's a starving young actor. If I wasn't buying him health insurance, he wouldn't have it. You know that. He's starving, and he's an actor, and he convinces me that I got to buy his health insurance for him. He's good. He's really good. You got a lot of young people. You got adults you got people who self-insure, who don't worry about buying insurance because they're well off. You got workers who don't sign up for employer-covered insurance because their spouse has coverage at another job. The statistics are all over the place, but we know something, and that is what Tom said. That we do know that even when you get insurance, you don't necessarily have good coverage. From our perspective, let me shock you, half of the prescriptions written in America don't get filled. Now, we give away free medicine to everybody living under 200% of poverty. So who's not filling their prescriptions? It's people living, some with insurance, many with insurance, above that percentage, who can't make the co-pays. Because insurance generally covers about 97% of your hospitals and doctors, only covers 67% of the medicines that could keep you out of the hospital. That's the average. So you got a lot of folks out there going to the pharmacy and saying, can't do the copay. You can argue whether they should, because they will buy a ticket to a ball game, and they do a lot of other things other than filling their prescription and staying adherent. But the bottom line is there are barriers like that operate because insurance doesn't cover well. And you can't escape that. We need a better program. We need insurance reform along with healthcare reform in the process. And insurance companies are ready to do that. And we heard from some of the big ones that they're ready to start wellness programs, a reward with premium reductions and copay reductions, healthy behavior. That ought to not be the exception. That ought to be the rule. It ought to be the rule in Medicare. It ought to be the rule in Medicaid, in veterans, in all our programs. That's Chip, everything.
Bottom line is we can get everybody enrolled if we set our minds to it. We're going to have a big outreach and an ombudsman program because if we're going to give people choice, we've got to give them an opportunity to enroll in the plan that they want. But remember, we're going to have a basic plan that is going to cover all the basic services for health care, and then we're going to get people into that. And we're going to subsidize those that can't afford it. And sure, we can do the whole thing. We can find as many as we can and auto enroll them and get the thing done.
Auto enroll. With all these preachers, it was funny. One of them said, in my church, I try to encourage people to sign up for these programs. I said, well, all due respect, Reverend, a lot of those folks don't come to your church. And he said, but if they don't come to my church, how can I help them? I said, well, all due respect, I don't think Jesus Christ stayed in the church. He went out there and he worked him. Maybe, but it's hard work. It is hard work. And sure auto-enrolling may be the only way to get it done.
Yeah. Eventually you have to go to auto-enroll.
But the ugly truth is that the cost involved with auto-enrolling, even for SCHIP, is so expensive, and we haven't had a system to finance it. And
that's correct.
And as soon as we can come up with this financing system that allows us to auto-enroll, that's by far the easiest and best way to do it.
But I can't let that go, because Congress does that all the time. In the Medicare Part D program, we provided a benefit for seniors that provided, during the 2 years of implementation, $600 free to every senior who needed it to pay for their medicines. $1,200 a couple. You know what the take rate on it was? 18%. You know why? Because government didn't want to talk about it too much because they didn't want to have to pay for it.
That's right.
Why build a program for people to use if you aren't bold enough to say you're going to talk to the appropriator and get the money?
Which is another reason we need our federal health board.
We certainly can. Yes. And we shift that easily.
Yes. Clearly, all of the programs you're talking about are mediocre. Even single payer is mediocre because none of them have anything to do with health, care, or harm. They simply are looking for a way to pay for the vulgar, greedy medical system that we have that is an embarrassment to the history of healthcare delivery. And so I want to propose a fourth category for how things could be paid for, and that would be intelligence. Intelligence, creativity, and find people who, as I know, exist all over this country who want to serve humanity and do a serve humanity design that could easily cut the cost of health care delivery by a half. How is it that I don't hear and never hear anywhere in any discussion about health care reform that has to do with the intense beauty of serving humanity in the healing arts?
This does raise a very good question about public service, about volunteerism, about grassroots efforts, and obviously that's an element you cannot legislate. But how do we foster and encourage that? Volunteerism is a big issue. We've touched on it at Time Magazine on numerous occasions.
Well, not only volunteerism, but I think this whole notion of individual responsibility. Is healthcare a right? I think it's a moral right. But there's also a fundamental responsibility that each of us must take upon ourselves, not only to pay for insurance, but to keep ourselves healthy. I mean, the last forum here in this room, right before this one, was about how one does that, and there was an excellent group of panelists talking about that. But we can't expect our healthcare system to solve this whole problem. This is a societal problem. And we've got to understand that as a society, we need to do a whole lot better job of creating a new mindset about individual responsibility and individual health that we just have lost track of for the last generation.
Yeah, I want to add that, we can say a lot of tough things about our country, but it's one of the most generous and caring countries I've seen around the world. And people do have that spirit and want to very often do it when you give them a chance. The community health clinics are a good example. I mean, I created the first one in my district with a lot of opposition from conservative health care. It worked beautifully. It lowered the cost. People are volunteering, helping, working out. And they're getting much better preventative medicine in these community health clinics. I love community health clinics. I really think they work. Nurses volunteer. Nurse practitioners volunteer. And many of those things happen in our country. When Katrina hit, I went to the triage centers and saw the spirit of our country. I've went to some of the refugee centers around. People from my city, New Orleans, ended up in all 50 states. I went to a lot of those refugee centers. I saw what people were doing. My own companies were all over that, all over the triage centers. We did about $180 million for free medicine just for the Katrina victims. People do that in our country. Look at what we did for the tsunami. Look what we did for the earthquakes in Pakistan, etc. So that spirit is alive, and it's true, but that still doesn't take away from the fact that we got a healthcare system that we got to fund in this country. And that's what this debate has to settle.
Yeah, I agree with Billy that this country volunteers like no other country on earth. We are caring people. What we need to have, and what we, I think, do have now, is the kind of leadership at the top that can lead us in the right directions and mobilize us to get these things accomplished. If you can aim in some way at obesity in America, and you pretty well start with children, childhood obesity and end-of-life expenses, you take two huge chunks of the cost off the table. Now, the difficulty is either one of those, and that's why I say we need to look at our whole system.
One of the other things, Jeff, that we should do, and I hope we do this year, is quadruple our budget for the National Health Service Corps. We have a chronic shortage of providers in this country, and we've really eliminated virtually all of the funding for the National Health Service Corps, and we need more providers, and we need nurses, we need doctors, we need nurse practitioners and physician's assistants, and I'd like to see a quadrupling of the National Health Service Corps to pay for the school that we'll need in order to get the kind of students and ultimately the kind of providers we have to have in this country to change our paradigm from illness to wellness.
Well, Dean Kamen, in one of the meetings we had, made a hell of a good point when he talked about the incredible amount of money our country spends on other things. 400 some odd billion on sports. I'm not knocking sports. I like sports, but where are our priorities when you think about healthcare? And Tom is right. That's a clear place where we missed the boat. Rural parts of America don't necessarily have family physicians available to them. It's the public service physicians that serve that gap. It's the one I worked with in Louisiana to create the first community clinic. We've got them all over the state now. That's a vital element of it. And that does attract all that volunteer spirit and assistance when you seed it with a federal interest in underserved areas of our country. It's at the bottom of many of our disparity problems in the country. The fact that you really don't have the kind of care in various communities of the country because it's just not commercially a good place for physicians and others to set up shop.
Can you speak up just a little?
Dave, you're going to ask? I can't hear you. I'm sorry.
I'll give you the mic next. I was shocked to find out that the prevention and wellness areas of resources, potential resources, aren't being put into the 1.3 trillion cost accounting, because I think it has an enormous potential. I've seen it here in this valley. We started no smoking here. You know, we've done a lot of innovative things in the Aspen Valley, the Aspen Institute. And we have the Wynn Health Institute in this valley that's probably the finest integrated healthcare facility in America and should be looked at as a model, because we need to look at what works so that we can shorten the long curve you've talked about of social change with evidence-based models that are working. And if it's working, let's champion it and look at it so that we can get some cost accounting from the prevention and wellness side, because that is huge. We have amazing health care and lowered the cost with an IP system, child prodigy center, all kinds of things. So we're teaching education to the youngest ones about what to eat and grow and all of that. I also love that you're talking about the role of an ombudsman, which I studied in Scandinavia some years ago. And we have proposed to the president that he create a role of the ombudsman and put someone there that knows a great deal about healthcare, foreign policy, and coordinating things. And we have nominated Senator Daschle for the role of the ombudsman because we think you would be ideal. So I just wanted you to know that one's coming.
Can we pass this by acclamation?
Yes, I'd like to do that.
Any thoughts, responses to that?
You want to respond, Tom?
If nominated, I will not serve. I think. But somebody should.
First of all, I'd like to thank everybody, because this is an exciting number. 1993 very well. We seem to go through these cycles of excitement and then disappointment. So let's hope we get somewhere this time. Two things, in fact. One is a concern that I have, and I've worked in many different parts of the world, spent a lot of time working in the UK, lived in the UK for 20 years. And there's a fundamental difference between the UK and here that we don't address. One of the basic rules I have in healthcare that I tell people about is you always follow the money. So we can do the payment reform, but the real issue is the incentive reform. And the problem we have is that if I'm a patient, we talk about chronic disease, that's a lifelong, longitudinal condition. So we need to think about managing clinical risk over a long period of time. Yet our financial risk is short-term. When I last talked to Humana, their membership changed over 20% a year. Yeah. The reality is they can talk the talk, but they don't walk the walk because there's not the financial incentive. Mm-hmm. In fact, they can't. Yeah. And this is a huge, huge problem in this country. And then some of the other folks, Jay in the back, talked about the financial incentives related to procedures. And we had a thing called capitation. We thought capitation was going to take over the world. One of the problems with capitation, of course, was that everybody misunderstood it. They thought you make money by squeezing the back office. What they didn't realize is you make money by managing the patient over the long term much more effectively. But nobody knew how to do it. So to what extent are we going to address those financial issues? Because we can go to a single payer, we can go to a multi-payer. It doesn't matter until we address the financial incentives. The second point, and this is for Tom, having worked in the UK system is very good in many respects, but it has a fatal flaw. Not fatal, and we have many fatal flaws if we're going to talk about fatal flaws. But it's that the NHS is highly politicized. Every single year, the NHS has to go to Parliament for its allocation of funds. That means the party in power is very, very short term. And I've been there where the Secretary of State for Health will get on the telephone and scream at a chief executive of a hospital because a little old lady tripped over a mat and injured herself.
We can't have that. So I think the idea of trying to develop a system where we perhaps have multi-year budgets and we try to depoliticize with accountability the oversight of what we're trying to do nationally will be very, very important. Otherwise, we're going to have a lot of micro-meddling. Thank you.
Well, I don't think you could have said it any better. I agree with 100% of what you said. I think that it's so important that we depoliticize. I think it's hard. You know, members of Congress are called upon. The three of us have voted how many times on what the reimbursement rate for oxygen is? Now, for the life of me, I can't tell you what the reimbursement rate for oxygen should be.
Can't either.
Nor should it be my business to vote on the reimbursement rate for oxygen. But that's the level of, and Billy uses I like this word, granularity. That is the granularity we have with regard to medical management in the United States Congress today. And you talk about politicized, that is a very politicized decision. Home health care is extremely politicized right now.
Yeah.
And, you know, the politicized decisions go on and on and on. And that is part of the reason we're in the mess we're in today.
I don't know whether we should price oxygen either. All I know is that I'm from Louisiana, and you got a low dose of oxygen in the air up here. You got a real problem. Let me talk about your first issue. One of the biggest problems, you're right, is the fact that it is not commercially viable for an insurance company to invest in your good health. It just isn't, because they don't know if you're going to be around. Dean and I were talking about that earlier, and I said, Dean, would you spend a ton of the money in your company to give all of your employees a great new education, master's and PhD degrees, unless you signed some agreement with them that they'd come back to work for you? You wouldn't do it. You wouldn't be educating everybody with your dollars for some other company to get the benefit of it. That's essentially what happens in America because of non-portability of insurance. If an insurance company knew you're going to stick with them long term, or when you're working with a company that has long-term benefits for employees and you can invest in their good health, then it makes sense to do that and to put programs together for healthy living and to reward those healthy living individuals with financial awards of some kind. I think you can solve a lot of that with portability. I think you can solve a lot of that with in the private sector, because as more and more companies are beginning to realize there's a big bonus in productivity for doing that, not just in the dollars you save in terms of health care. But when sick days go down, when workers are not ill and sick and they're not hurting each other because when they're present, but there's a thing called presenteeism they've identified now. We all know it. It's that Monday morning when you come back from a weekend when you can't really do your job. You're present, but you're not there, you know. That all those factors come down, the company benefits, it gets to there's an economic incentive to do that. So you hit it on the nail. How do we realign the incentives so companies want to do it more, our public systems want to do it more, and even more importantly, how do we get the insurance companies to have a portability arrangement that encourages them to literally invest in their customers' good health?
I wanted to make a comment. I have the microphone, though I don't know if I'm using it. This is interesting for me because I'm a teacher and I've gone to many teachers' meetings, generally at this time of day, and I thought teachers talked a lot and went on, and now I realize that they are missing what politicians do, which is you guys are the best talkers. You win over my teachers all the day. So I wanted to insert in there the fact that in my counting, you have mentioned cost 114 times in the last 45 minutes. And the word cost, and I wanted to read from something. You might recognize this. This is put on by the Aspen Health Stewardship Project, which, by the way, is what we're at, or is a part of what we're at. It was just finished in March 2009, and I think started in 2007, and I didn't write it. I just wanted to read a little bit their perspective on how many...
One sec, just before you read, if you
Yes.
could synopsize it, because we do have a flashing red light here. We've gone over by 5 minutes, and they have to get
I'm sorry.
the next group in here. So
Okay.
if you could summarize
Yes, I'll
that,
make it
and
very
we'll
brief.
definitely
All
get
right.
an answer here.
They say here, access for all is necessary, but not enough to fix today's problems. Nor is it affordable, okay, 112 times, under our current system. Simply put, the current debate, of which I think you represent, fails to acknowledge that health is a national resource and its stewardship a shared responsibility. One last statement here. The existing preoccupations with who is responsible to bring about the needed changes and who should pay for them are distractions, gentlemen. Thank you.
Okay. Thank you very much. That is strongly and persuasively put. I'm told that, anyway, thank you. I'm told that food and refreshments will be brought in, so we don't have to scatter quite as much here.